It's working. आ गया
जो लिंक था जो सब्जेक्ट जो हमने शेयर किया ना उस लिंक से नहीं आ रहा है, उस पे नहीं आ रहा, दूसरे
स्टूडियो 1 पे ही आ रहा है।
नहीं स्टूडियो 1 पे तो आ रहा है लेकिन वो जो लिंक है वो
नहीं, लोग जिस लिंक को शेयर किया है
वो लिंक खोलते हैं तो नहीं, वो हर जगह वही लिंक है।
ये देखो ना,
पूरे
ये देखो मैं
व्हाट्सएप पर लॉक खोलो,
एक मिनट,
आपको एक व्हाट्सएप सर्च करके आ रहा है वो लिंक।
ये देखो, ये जो है ना स्टूडियो 1 का,
ये वाला,
हाँ इसी को मैंने आपको क्लिक कर रहा हूँ, भेजो। ये है ना, ये यही है ना आपका?
आ गया मेरा नहीं आया,
देखो आ गया सर, अभिषेक सर। ओके,
पता नहीं, मेरे को तो पता नहीं चल रहा है।
ये देखो
ठीक है
सेम लिंक
सर, आइए देखिए,
आप टेंस हो गए
आपने और क्योंकि लास्ट सर, चलो
स्टार्ट करो। Good afternoon. I welcome you in the series of postgraduate teaching in RP Center. I'm really thankful to Chief RP Center is started this program, and today in this sequence I'll be talking about national program and strategies for blindness and visual impairment beyond COVID-19. As you all know that the number of cases in India is now more than 100,000 cases, but probably we are a little bit less tense compared to the time when the number of cases were 5,000. At that time, although OPDs, routine OPDs were blocked, only emergency services were allowed. But now at this stage, what we are thinking that we should start routine services, routine program in our country. And in this series today, I'll be discussing about the National Program for Control Blindness, how we can come back to the routine services. In my lecture today, I'll be discussing about the National Program for Control Blindness, a basic brief of the program, a recent finding of National Blindness Survey, and also about the various guidelines which Government of India and PCB has developed in relation to COVID. So India was the first country who started National Program for Control of Blindness way back in 1976. And National Program for Control Blindness is taken as a key policy maker for the country. It monitors the program, it do the evaluation work. He is a budget provider for various NGOs and other programs, and also it is taken as a guide and support. So various guidelines are being given by National Program for Control of Blindness. The program was initially 100% centrally sponsored program, but currently it based on partial sponsorship. Partially, nearly 60% of funds are given by the central government and 40% by the state government, except in Northeast where 90% funds are being given by the central government. And it is actually working on decentralized base. Basically, a district-based planning is done, and it is probably the single largest program which is currently present in almost all the districts. And as per 2011 census, there were around 640 districts. It was present in most of the districts in the country. Beyond 12th five-year plan, that means after 2017, it was actually the guidelines, the targets were developed by Minister of Health and Family Welfare for 3 years until 2020, and it is now a part of national non-communicable disease component of National Health Mission. The goal of National Program for Control of Blindness was to reduce the prevalence of blindness to 0.3% by the year 2000, which was later on revised to 2020. And as per the National Health Policy, the goal is to reduce the prevalence of blindness to 0.25% by the year 2025. But now we also follow the WHO guidelines for universal eye health. And as per that, the global action plan for the year 2014 to 19. The aim of that program is to reduce the prevalence of avoidable visual impairment by 25% by the year 2019, where a baseline of 2010 has been taken as the initial setup. In order to understand the governance of the program, National Program for Control Blindness, it is based at the Ministry of Health and Family Welfare, Nirman Bhavan, as part of non-communicable disease, and one joint secretary is in charge of the program. Whereas from the technical head, one Deputy Director General and the DGHS, that person is in charge under NPCB and VI. And at the state level, we have state program officers who actually implement and monitor the program at the state level. And at district level, we have district health societies which are responsible for accessibility and quality of eye care services at the district level. This is one graph which shows the trends of blindness in our country. When program was started in 1976, it was based on finding of ICMR survey, which was conducted from 1971 to 74. And at that time, you can see the prevalence of blindness in general population was 1.38%. In 86-89, it was 1.49%. The significant changes were done in the program, and a World Bank project was started in relation to cataract surgical services, and a lot of funding was given by WHO. And in 2001, we got a prevalence of 1.1%, and in 2000 it was 1%. But you can understand this is well below the goal of 0.3%. In 2007, we according to the survey in 2007, the total number of blind people in India were around 12 million. But here in all these surveys, the definition of blindness was presenting visual acuity less than 6/60, whereas the WHO follows the definition of blindness as less than 3/60. So the key objective of National Program for Control Blindness is to basically work on 5-6 major objectives. The first one is to reduce the backlog of blindness through identification and treatment of blind people. And you can understand the majority of blindness due to cataract, so it is mainly cataract-centric program so far. Then developing comprehensive eye care facilities at each level, that is from starting at primary level at primary health centers, community health centers, to secondary level in district hospitals, and at tertiary level in medical college and regional institute of ophthalmologists. Develop human resource, that is ophthalmologists and paramedical ophthalmic assistant and other paramedical staff for eye care. Then improving the quality of services, that is another major objective of this, the National Program for Control Blindness. Of course, the program work on participation of non-government organizations and private practitioners, and one of the major objectives since the beginning is community awareness about the eye care facilities and diseases. Now, defining blindness as per WHO, as I mentioned, the blindness is defined as the presenting visual acuity. Just remember, it is not best corrected, it is the presenting distance visual acuity less than 3/60 to PL negative, whereas we have different levels of visual impairment. The severe visual impairment is when the presenting visual acuity is less than 6/60 to 3/60, and moderate visual impairment is less than 6/18 to 6/60. What WHO says, the term visual impairment means it is the moderate visual impairment plus severe visual impairment, and also blindness is also part of visual impairment. So all people with visual acuity less than 6/18 to PL negative, they come under part of visual impairment. Beside this, the WHO also recently introduced the early visual impairment component, and that is defined as when the visual acuity is less than 6/12 to 6/18. Now, National Program for Control Blindness recently conducted National Blindness and Visual Impairment Survey. The entire survey was conducted by a team of RP Center in nearly 31 districts of the country, and around 93,000 population was covered. The report was released recently by Health Minister of India on 10th October 2019. That was on a World Sight Day. I would like to share the findings. The survey was conducted in 50 plus population, and the prevalence of blindness in 50 plus population was 1.99%, where the prevalence of visual impairment, that include MSVI, moderate visual impairment, severe visual impairment, and blindness, it is 13.76%. So 13.76% visual impairment, 1.99% blindness. This is the key finding of National Blindness Survey. And if we see the blindness as per the gender, you can see all type of blindness and visual impairment is higher among females. This is something very important, that we need to give more priority to female patients. Among age-wise, though the survey was conducted in 50 plus, still you can see the prevalence of blindness was much higher in 80 plus age group. It was 11.6% than in 79. That means the blindness is directly related to age. This is very clear from this survey. Comparing urban and rural population, the prevalence of blindness is higher in rural population compared to urban population. As we know, the services are less available in rural areas compared to urban. And as for the literacy wise, education wise, you can say the blindness is much higher among illiterate population compared to the literate populations. The survey was conducted in 31 districts, and you can see the national average was 1.99%. The prevalence was much lower in Kerala, in Goa, in Gujarat, whereas it is much higher in Bijnor district of UP and Warangal in Telangana. We conducted survey in 0 to 49 age group also, and finally we came out with the figures, which is the prevalence of blindness in overall population, blindness and visual impairment. You can see the prevalence of blindness in overall population as per this survey is 0.36%. Probably a very positive, very nice figure, that it's quite near 2.3. The current prevalence is 0.36%, and overall visual impairment including blindness is 2.55%. Now this figure shows the WHO goals. That's comparison of blindness and visual impairment compared to the baseline 2010. The prevalence of visual impairment in 2010 was 5.3%, and now it is reduced to 2.55%. That means nearly 51.9% reduction in visual impairment in last 9 years. Whereas in blindness, 2010 WHO estimate figure for India was 0.68%, and now it is 0.36%. So you can say 47.3% reduction in blindness. So against a goal of 25%, we have achieved nearly 50% reduction in blindness and visual impairment. Among the causes of blindness, though the overall burden is significantly reduced, but if we see among the causes, cataract, which is very much avoidable cause of blindness, it is a major cause of blindness in our country, and nearly 2/3 of blindness, 66.2% of blindness is due to cataract. Whereas other major causes are the non-trachomatous corneal opacity, and that is nearly 7.4%, whereas the cataract surgical complication is the third major cause, responsible for 7.2% of blindness. Beside this, glaucoma and other causes, but the important thing is that the refractive error is no more an important cause of blindness. If we compare these data with 2001 National Blindness Survey with figures which we are using till now, cataract 62.6 is nearly 66. There's not much change. But then refractive error, which was responsible for nearly 20% of blindness in 2001 survey, now it is just 0.1%. But whereas the corneal blindness, which was just 0.9% at that time, it is 7.4% at this stage. This is something big change that we have to give more emphasis to corneal blindness. Diabetic retinopathy, though it is a common disease, the retinopathy, it is quite common, but as far as blindness is concerned, blindness due to DR is probably much less. This is just around 1% in our country. Now cataract surgical coverage was an important component of the national survey, and I would like to inform you that the cataract surgical coverage is defined as total number of cataract surgeries conducted divided by total number of cataract surgeries required. And this requirement can be based on the factors like whether surgery among people who are cataract blind, that is having visual acuity in the better eye less than 3/60 due to cataract, or less than 6/60 or by 6/18. You can see that 93.2% people, they were covered with people who are having cataract, they're covered with cataract surgery. That means only 6.8% people who were cataract blind were not operated. But this is also very important that only these 6.8% people who are not operated, they are responsible for 66% of blindness in our country. If we see the 6/18 cutoff, that is the visual impairment cutoff, then nearly 75% people who are having visual acuity less than 6/18 in better eye, 74% of them have been operated in our country. Another aspect like percentage of surgeries conducted by government sector and NGO sector, I would like to inform that Nearly 60% surgeries in our country are being conducted by the NGO or private sectors, and around 40% by the government sector. So that directly shows that the involvement of the NGO sector is very much there in the National Program for Control of Blindness. As far as the quality of cataract surgery, the visual outcome of cataract surgery concerned, only 57.8% of people who are operated for cataract, they have their visual acuity better than or equal to 6 by 12. Another 17.7% has visual acuity good between 6 by 18 to 6 by 12. So nearly 75% of people, they have their visual acuity better than 6 by 18. Whereas just see, nearly 11% of people, they have their visual acuity post of visual acuity less than 6 by 60. This is really of great concern, because as per WHO guidelines, this figure should be less than 5%, and we have around 11%. And the figure better than 6 by 18 should be more than 90%, and we have nearly 75%. That means a lot of emphasis still required in terms of quality of cataract surgery. And if we need to understand what the reasons for such poor outcome in the country, you can understand it is basically the ocular comorbidities and the operative complications are more important, and the refractive error and long-term complications are probably less important as for the cause of poor or moderate borderline outcome of patient operated cataract surgeries are concerned. Now, beside this National Blindness Survey, the survey was also conducted on diabetes and diabetic retinopathy. I'll cover briefly very important findings. The overall prevalence of diabetes in 50 plus population was 11.8%, and that included only 2/3 of non-diabetic and 1/3 of new diabetic. Here non-diabetic were defined who were already taking treatment for diabetic retinopathy or was having blood sugar more than 126 fasting blood sugar, whereas new diabetic, we did blood sugar of all the individuals, and if the random blood sugar was more than 200, then person was labeled as new diabetic. The prevalence of diabetic retinopathy among diabetic was 16.9%, whereas the maculopathy was 7%, and the sight-threatening diabetic retinopathy was 3.6%. Here I would like to inform you that survey was conducted in nearly 63,000 population in 21 districts of the country, and you can see among all those districts a varying range of diabetes and diabetic retinopathy. We have North India, where prevalence of diabetes and diabetic retinopathy was low, except in Kapurthala in Punjab. But in South India, probably the prevalence of diabetes and diabetic retinopathy was much higher. In Kerala, in Tamil Nadu, in Karnataka, Andhra Pradesh, it was much higher. Being based on these surveys and the current strategies, the National Program for Control of Blindness give emphasis to these 6 major disease or group of disease: the cataract, refractive error and low vision, corneal blindness including trachoma, childhood blindness, glaucoma, and diabetic retinopathy. Probably all these disease avoidable causes, they are responsible for nearly 90 to 95% of avoidable blindness and visual impairment in our country. So if we give emphasis in these 6 diseases, probably we can reduce overall burden of blindness and visual impairment. Some of the achievement of National Program of Control of Blindness, these have been taken recently from the NPCB website. These are targets and achievement for the year 2018-19. We kept a target of 66 lakh surgeries for cataract, and you can see we achieved more than 66 lakh. It was 66.9 lakh surgeries. Where for other disease like DR, glaucoma, ROP, pediatric surgeries, keratoplasty and VR surgeries, the target was 2 lakh, and you can see the achievement was 6.14 lakhs. A very good initiative taken for other disease beside cataract. The third important component, the spectacles for school children, against a target of 9 lakhs, 8.82 nearly we achieved these targets also. And the last one is for the collection of donated eyes for corneal blindness. We had a target of 55,000 collection, and we achieved 68,000. So as far as the achievement in relation to targets are concerned, this is extremely good. But only if I need to critically review the program, I feel these targets are not sufficient. Even for cataract, based on the current blindness survey, we assess and give figure that we nearly need 200 lakh, 2 crore surgeries per year if we need to eliminate cataract blindness in our country. The key program activities for National Program for Control Blindness, these are the major activities. One is the free cataract surgeries that we are conducting. Second, the school vision screening, and we are providing free spectacle to school children. In fact, the component of presbyopia have been recently added in this one, and the presbyopic spectacles are also provided free of cost. Then collection of donated eyes, the free keratoplasty is been provided as part of national programs. Diagnosis and treatment of other diseases like DR, squint, glaucoma, low vision, childhood blindness, and ROP is there. Then for infrastructure upgradation, it is for the vision centers, eye banks, ward, and NPCB is providing funds for all these activities. Then training of eye surgeons and paramedical ophthalmic assistant, IEC activities, and monitoring workshop. The amount which NPCB is giving presently is for cataract surgeries. They are giving rupees 2,000 to NGOs per cataract surgeries. For DR, childhood blindness, again it is rupees 2,000. For a keratoplasty, it is 7,500 rupees. For VR surgery, it is 10,000 rupees. And for spectacles, whether it is for school children or presbyopic spectacle, it is rupees 350 per spectacle, per pair of spectacles. And for cornea collection, if it is eye bank and processing is included, it is 2,000 rupees per pair of eye collected. And if it is eye donation center without processing, it is 1,000 rupees. Now, as I mentioned, cataract is the major concern. Cataract is the leading cause of blindness, and we have planned to make India cataract blindness backlog free in phased manner. The key strategies for this is to assess the current magnitude. For this, the National Blindness Survey has already been conducted, and we know the magnitude is very high. Then utilizing healthcare volunteers, let's start from ASHA workers to eye care volunteers. They can screen and go house to house. They can identify the visually impaired and blind people and then refer them to vision centers. This is one strategy so that we can get the demand can be generated, and awareness can also be created in the community to generate that demand. Then there is need for more infrastructure, the eye care facilities, surgical facilities, equipment, and for that NPCB is dedicated and ready to provide to various agencies, NGOs, and even the government sector. Plus, there is need for high volume cataract surgeries in a mission mode. Now with COVID, probably this important target may miss, because now it may not be feasible to do high volume cataract surgeries. And of course, NPCB is giving due importance to quality of care, and in various technical and operation guidelines have been developed for that. Now, if I want to compare the cataract surgeries in relation to COVID-19, one thing is very sure: the demand for cataract surgeries will reduce, because cataract is mainly seen in the old population. And as we know that even COVID is more common and its mortality is high in old population. So people above 60 or 65 year age may not come to hospital for surgeries. They also have more comorbidities. So this is one issue where we are very much concerned, that people have fear of corona, and old age people, they may not come for cataract surgeries. So it is very important that the eye care providers, they need to create awareness in the community about the safe facilities for surgeries. Even old patient is there in our hospitals, that confidence need to build for these patients. And we need to create a team of healthcare volunteers who can go house to house and convince old people for cataract surgery. So demand generation is an important issue. As far as high volume cataract surgery, as we mentioned, in one hospital probably it is not possible to do thus large scale of surgeries, because we need to take all the COVID precautions. So it is suggested that more and more secondary level hospitals should be started, and that should be more in the remote areas where patient can have facilities near to their home. That is the need, that infrastructure equipment development should be there, so that we can think of having more facilities as far as cataract surgeries are concerned. And third component, the cost of cataract surgery is going to increase because of all COVID precautions. And for that, I have a strong doubt that Government of India will increase fund in eye care program, because currently the priority is the COVID. So the best possible solution, what I feel, is that eye care, the cataract surgery, should remain as part of the Ayushman Bharat. It is there in many states at this stage, but there are a lot of discussions that cataract surgery may be removed from the Ayushman Bharat because the funds are being provided through NPCB. But my suggestion at this stage is that all the agencies of working for eye care, whether it is Vision 2020, NPCB, we need to try our level best that cataract should remain as part of Ayushman Bharat, and not only cataract, more procedures should be included. Currently we have 40 procedures. Initially there were 42, now 40 procedures are there, and we need to read more procedures, and more money should be provided. Because of COVID, since the cost of surgery is increasing, so more money should be provided for cataract and other surgeries in eye care. The other important aspect, the school vision screening program, it was started way back in '94, and it's based on initial screening by the teachers, and then after primary screening, the refraction is being conducted by the optometrist, and finally free spectacles is provided through the district authorities. Probably I feel, as far as COVID is concerned, the school are not open, so the program is already affected, and I believe it will take some time in opening of schools. But I feel once the school will open, probably we can conduct this program in a normal routine manner, keeping all the safety precautions of physical distancing, etc., mask, etc. But the routine activity program can be taken care of, and it is not of much concern once the school will open. But we are not sure when school will open, and whether for this year we'll be able to achieve the target for school vision screening program. Another important area where National Program for Control of Blindness is working is basically for trachoma elimination. WHO has a goal of eliminating trachoma by the year 2020. It is already 2020, and in India, the elimination criteria for WHO is very clear, that in person above the age of 15 years, the trachomatous trichiasis, which is unknown to the health system, the prevalence should be less than 0.2% in each district. This is one criteria. Whereas in children between 1 to 9 year of age, instead of TT, we look for the active trachoma disease in terms of trachoma follicle, trachoma intense, and the prevalence should be less than 5% in each district and should be sustained for at least 2 years. And the health system should be able to identify and manage new trachomatous trichiasis cases. So as far as our country is concerned, the national program is extremely dedicated in terms of declaring trachoma elimination. In 2017, we already declared trachoma in children being eliminated, and in fact, against a prevalence of 5%, we got a prevalence of just 0.7% in the country. So in children 1 to 9 year of age, it is already trachoma free. But as far as trachomatous trichiasis is concerned, we had a prevalence of 0.35%, and we need to go to a prevalence of less than 0.2%. And for this, we have adopted this safe strategy, that is surgery, antibiotic, facial cleanliness, and environment improvement. This is being implemented in all the previously hyperendemic areas. In fact, now we are planning, as part of NPCB, that 200 districts have been identified in the country were previously hyperendemic, and TT only survey will be conducted in all these 200 districts in next 1.5 years, so that we can declare that India is free of trachoma. In fact, after that, we will be submitting a dossier to WHO for validating our country that it is trachoma free, and we're expecting by the year end 2021, we will be eliminating trachoma from our country. Now I'll be coming out to some of the guidelines which are being given by the NPCB in relation to the functioning related to the COVID-19. These guidelines were recently given by NPCB on 8th May 2020. And I would like to give some important things, that as far as all eye care facilities, they can carry out their routine clinical activities, including OPDs, IPDs, and surgical procedures, of course, including cataract, except in the containment areas of red zone. That means in green zone, orange zones, even in red zones where containment areas are there, the government is allowing to do cataract and surgeries and other routine procedures. But they are very clear that we need to take all the precautions to prevent the spread of infection, and these precautions are social distancing of at least 1 to 2 meters, wearing of face mask, face shield, and goggles as per the guidelines, and frequent washing of hands and hand rubs. That is all the guidelines are being issued by Ministry of Health and Family Welfare in this aspect. And they have expected that the SOPs regarding all these guidelines should be given, and I'm very happy that the RP Center already developed these guidelines, and in fact those guidelines are much more strict, and these can be maybe followed by other institutes also. They said that they have to ensure minimum touch of OPD cards, trial frames, trial lenses, and other things which are used in IOPDs, and their frequent disinfection is required. Ensure patients should wear face cover, face mask, and they should use hand rubs whenever they are entering in the OPDs. And any patient suspected of COVID-19 infection, they should be screened, and in fact a special consent form should be used for all the patients. So these are the screening question and consent forms. They have been given by the Government of India. They can be used in all the OPDs for screening COVID patients. And then NPCB also says that at this stage no outreach camp should be undertaken, and in fact no mobile van should be sent to the field. This is very important, and we are not sure whether how long it will take to start camp, because it is very difficult to maintain social distancing guideline in camps and in mobile vans. So currently it is not being permitted, but Government of India, they promote teleophthalmology and teleconsultation practices. In fact, the telemedicine guidelines have been given by Government of India. It is expected that even the eye care providers, they should use those guidelines for teleophthalmology and teleconsultation. In fact, they also recommend that IC message should be given, but through digital means, through telehealth system. As far as iBanking is concerned, at this stage, the Government of India is very clear that no eyeball retrieval should be done from homes. However, the hospital cornea retrieval program can be continued in the non-COVID-19 patients, dead patients, but these cornea, when surgery is required, they should be done mainly for therapeutic purposes and should avoid at this stage for the optical purposes. During surgical procedures, the surgeons and the OT team, they should follow all the guidelines given by Government of India in relation to various surgeries. And beside this, one thing which I would like to clarify at this stage, that the pre-surgical COVID-19 test on patient is not mandatory by Government of India. In fact, but it depends on the institute. If they want to form their own guidelines, they can do this COVID-19 test before surgery, but it is not mandatory as far as Government of India is concerned. This is one slide. It looks very thick slide, but I have just summarized all the PPEs, the guidelines which have been given by Government of India. The most important thing which we should understand, that our ophthalmic practices that comes under the moderate risk group, and where it has been recommended to use N95 mask when especially aerosol generating procedures are being anticipated, to use goggles and face shield, and also latex examination gloves. This is the required recommendations by Government of India, but the institute, they are free to make their guidelines. They want to make more strict guidelines. As for the other services are concerned, whether it is help desk, registration counter, laundries, pharmacy, all these are part of the mild risk, and only triple layer medical mask and latex examination gloves is required for the people. And the supportive staff, the administrative and financial staff, they just need a face cover, nothing else, no gloves, nothing. This is the key recommendation by Government of India, and these must be followed in their routine procedures. Other point that should be remembered is the standard precautions to be followed at all the times. PPs are not the alternative to basic preventive public health measures such as hand hygiene, respiratory etiquettes, which must be followed all the times, and always follow the laid down protocols for disposing of PPs. That is very important, that the gloves and masks, they should be disposed of rightly in their respective red and yellow bins. They also recommend that if in case any COVID-19 patient is detected in any non-COVID health facility, then proper guidelines which have been given by Ministry of Health of Government of India, they should be followed in terms of isolating those patients and also the quarantining those contacts which have come close to them. Another important aspect which Government of India recommend for everyone, all healthcare workers and all patients, they should download this Arogya Setu COVID-19 tracking app in their mobiles with location enabled. And this is important app. In fact, I'm also using it. This provide data on the data related to COVID patients, and also if any patient is infected or high risk around you, this directly give information that this much of number of patients they are infected or having COVID infection around you. So probably everyone should these Arogya Setu COVID-19 tracking app in their mobiles. I would like to also emphasize that recently a very hard work have been done by the All India Ophthalmic Society, and they have developed ophthalmic practice guidelines in relation to COVID-19. It's a huge guidelines spreading nearly around more than 100 pages, and there's 16 different chapters, and there is one component of guidelines related to community eye health and vision center is also there, which was developed by team of RP Center, AIOS, the Ministry of Health and Family Welfare, that is NPCB, and the Vision 2020, and many other NGO partners, experts. So in order to like giving a brief about these guidelines, it has been advised that according to different zones, the vision center or primary eye care facility, it is advised in all green, orange and red zone. That means if we are running vision centers, we are free to run vision center except in containment zone. They should be started in all zones. Then transport facilities for camp patient, they can be started in green zones but not in other zones. Mobile van and camps, they are not advised at this stage by Government of India, so this should be restricted. Refraction facilities, except in containment zone, refraction can be started in all 3 zones. Reach in cataract surgeries, again except in containment zones, we are free to start our cataract surgeries. And teleophthalmology, this is one component which is also being advised in containment zone. So teleophthalmology and teleconsultation is one area which can be started in each and every zone in relation to COVID is concerned. Now, a few important thing about strengthening primary eye care. This is the right time that our country, we should strengthen primary eye care system in our country. And probably I suggest, instead of making our tertiary care hospital, secondary hospital as overcrowded, I feel that patients should be seen at primary level, and only referred cases should be sent at the secondary and tertiary level. By this, we can definitely think of preventing COVID infection at least in tertiary level hospitals. As far as primary eye care is concerned, there are 3 different components is there. Number 1 is the vision center, and there should one vision center for every 50,000 population, which is being taken care by one paramedical ophthalmic assistant. Below vision center, we have health and wellness centers for every 5,000 population, which are being managed by the this auxiliary nerve midwife or health workers. And now Government of India has recommended that one nurse or one person from alternative system of medicine should be available at health and wellness centers. And lowest level, at the community level, we have healthcare workers like the ASHA workers and Anganwadi workers and school teachers working for around 1,000 population. And probably I feel this system of primary eye care, this is the right time that should be developed. In fact, in national health policy also, it is being recommended that we should promote primary eye care facilities in our country. If we see our healthcare infrastructure, in the top level we have center of excellence. We need 20 such center of excellence. We already have 20. Training center of medical college, it was targeted that by the year 2020 we should have 200 training center, and we already have nearly 400 medical college if we include medical college in private sector also. Service center or secondary level centers, it was targeted that should have 2,000 such centers, and we already have more than 4,000 centers if we include the NGO facility in our country. But you see the bottom level is the vision center, that is primary eye care center. It was targeted that we should have one vision center every 50,000 population, and nearly 20,000 centers were targeted by 2020. But see, even at this stage we just have 4,000 vision centers. So probably this is one area of strengthening primary eye care, which is probably very right time that in post-COVID era we should develop our primary eye care services. As for the vision center, it can be integrated vision centers in primary health centers where only one medical officer is there, and the optometrist can join that center. Beside this, we can also have standalone primary eye care center, which most of the NGOs prefer. They can send their optometrist in the vision center, and he can manage. And these standalone vision centers, they can also be like they have tele-ophthalmology facility where they can remain in contact with the ophthalmologist, and they can provide proper guidelines to their optometrists. What services we are expecting the vision center at this stage during this COVID period is, of course, the early detection and treatment of eye care conditions. Even the first line management of emergencies can be done at the vision centers. Vision testing and reflection probably very much required and can be done. Dispensing of spectacles should be there and should be provided. Refer and triage of individual patient who needing surgery. That is very important. And all those patients who are having fever or suspected COVID, they can be stopped at the primary level only. They should not be referred to tertiary hospital unless they are proved that they are not having disease. And post-operative follow-up can be given at these vision centers. And probably the most important is the training of ASHA workers and the volunteers through telehealth. This component need to be taken care of, because the ASHA workers, they can be involved in the program very well. As I mentioned about health and wellness center, currently health and wellness center development is a key priority under the Ayushman Bharat scheme and Government of India. It is being targeted that by the year 2022 we'll be having 150,000 health and wellness centers in our country, and that includes sub centers, primary health centers, and urban health centers. And I would like to inform, by the February 2020, we already have 29,414 health and wellness center in our country. That means we are the right track. Operation guidelines have been developed for these health and wellness center. In fact, one task force was there for ophthalmology services also, and we have given guidelines related to what eye care services should be available in health and centers, and very soon these guidelines will be released. Probably they will be one of the centers for providing primary eye care center. The advantage is that the ASHA workers are linked with these health and wellness centers, so they can work under control of the in charges of these health and wellness centers. Now coming to the ASHA workers, we know that currently we have more than 1 million ASHA workers in our country, and they are part of Ministry of Health and Family Welfare. They are being involved in comprehensive health care, including eye care. So they can be a partner to vision centers, they can report to vision centers, they can work between community as a bridge between community and the optometrists. And what activities they can be easily involved is basically for eye healthcare educations and awareness in the community, so that to prevent blindness and also to avoid harmful traditional practices and misconceptions. They can also be used for identification of blind and people with common ocular mobilities. And the most important function they can do is they can timely refer the patient to the optometrist for further care. We have experience of utilizing ASHA workers in RP center. What we feel is that they are very poor in record maintenance. So don't try for record maintenance through ASHA workers. They are very good in awareness generation for the community. They can refer presbyopic patient with near vision problem. They are already involved in vitamin A prophylaxis very nicely in the community programs, and they can also be very good for referring patient to either vision center to base hospitals. So these are the things where we can use ASHA workers. But as far as identification of blind and visually impairment, if we ask ASHA worker to do vision screening by going house to house, probably they find it difficulties, because female ASHA workers, they find taking difficult, they have some social problem taking vision of old male patients from the same community. So there they find some issues in relation to distance also. There we need to work hard if we want to involve them into vision screening activities through vision charts or something. But in some areas, like a lot of NGOs, they find difficulty in using ASHAs because they are part of the government system. But I suggest if ASHAs are not there, they can use other workers like Anganwadi workers, school teachers, community volunteers, panchayat teams, NGO workers, even other health workers, and sometimes even the RNPs, general practitioners in the community, as their volunteers in eye care programs. Another important aspect in post-COVID area is the role of teleophthalmology. Till now, we were using teleophthalmology mainly for diabetic retinopathy and ROP programs. But it is right time that the teleophthalmology should use for all eye care services, and there should be communication between the vision centers and at the base hospital. And the ophthalmologist sitting as base hospital, they can provide full guidance to the people at the vision center. Even the telemedicine practices, teleophthalmology can be started. But one thing we must remind that the teleophthalmology, the optometrists are not permitted to give telemedicine services. They can be with the patient and can request ophthalmologist to provide services, but they cannot be the person who are prescribing medicine, other thing to the patient. Must take care about these things. In fact, the ophthalmologist, they should read the telemedicine, teleconsultation guidelines given by the government of India, so that to avoid any kind of problems related to legal issues in this matter. One thing which is being recommended is that we should have electronic medical records for all the patients, not only for telemedicine but in all eye care facilities. This is a need that all hospitals in the country, they should have electronic medical records. In the end, I would like to say that as far as this COVID, we have to learn living with COVID. It is going to stay maybe for 6 months, 1 year or 2 years, or maybe longer. But the new normal for everyone, every person in the community, is the social distancing, ideally 2 meters, but minimum 1 meter. Regular hand washing with soap and use of sanitizers, use of mask, use of disinfectant spray, some travel restrictions, and avoiding social gathering. This is for everyone. And as far as eye care providers are concerned, regular thermal screening for patient for COVID symptoms, for fever and COVID symptoms, clinical screening for COVID-19 patients, use of PPE in our services, whether it is OPD services or emergency services or operation theater, use of disinfectants, and promoting teleophthalmology and patient education through telehealth. Probably if we have all these things in our system, we can think of achieving targets near to what we have decided in our national program for control of blindness. Thank you very much. Thank you. हाँ जी, कितना टाइम लिया मैंने? 45 इधर से आना, इधर questions? No questions. Thank you. Sabyasachi Patnaik watching. They can see me now.
Yes. So regarding phacoemulsification, is it considered aerosol generating?
Phacoemulsification, Dr. Tushar बताएंगे.
As per government guidelines, it is.
The AIOS, they have recommended that phacoemulsification should be done with precaution. Probably it is taken as in fact now SICS has been given more important rather than phacoemulsification. So I'm getting some comments from people like Pranita Sai. She mentioned, thank you sir for the wonderful lecture. Navneet Sidhu, thank you sir. Vikas Jain with Vatika Jain, thank you, but no questions. What vision cutoff for school screening survey? 6/12.5. Afreen Bari, she has asked whether it is 6/12 or 6/9 cutoff. Previously the guidelines I can answer here. The guidelines were to have cutoff of 6/9, but recently Government of India, they have modified. It is now less than 6/12. Even WHO recommends 6/12. So now we are sticking ourselves to 6/12 cutoff for school vision screening program. Then Arpit, thank you. I'm searching for questions actually, but I'm getting thank you only. Sandhya Gaur, thank you. Great lecture. I think people are not interested in asking questions. Either it was very difficult or very simple. Use of NCT results in aerosol generations. Definitely NCT is considered aerosol generating, so NCT is probably not recommended for testing for glaucoma right now.
Then routine IOP measurement for that happen?
Yeah.
Application for routine IOP.
Yeah, of course. Dr. Sabyasachi Patnaik has written, it was well explained, so no questions. So I think thank you very much. Let's stop it. Thank you. एग्जिट OBS
स्टॉप स्ट्रीमिंग।
सर
बंद नहीं करना अभी
क्वेश्चन आंसर
हो गया